Benvenuti a un'altra grande puntata del talk scienzemotorie.com.
I don't wanna go back. Give it to me, I'm on. You should just know that. Tell me what you wanna do. I don't wanna go back. Give it to me, I'm on. You should just know that. Hold tight, don't let go.
Hello and welcome to another great episode of the Sports Science Talk Show. Today I'm glad to be here with Nicky Kirk. Hello, Nicky.
Hello, thank you for having me.
I'm very glad to be with you. Nicky is a chiropractor, professor, and a clinician at Parker Performance Institute, right?
You got it, yep.
You come from Texas.
Well, I live in Texas.
You live in Texas.
As you know, I come from Scotland.
From Scotland.
Originally, but I've been in Texas for 5 years. Now, it's going to be 5 years this winter.
Nice. I'm very curious about your journey. And in fact, the first classic question in the talk show is, how did your journey start?
It's an interesting journey. I think like a lot of people that move into sports science or the practice of medicine, had a family member who was my grandfather, who was an epidemiologist. But before that, he was a classic general practitioner in the days when general practitioners would see everybody in the community, in the neighborhood. So maybe he would deliver twins in one house, then he'd be shown into the good room at the next house, and somebody maybe has a hernia or appendicitis. The classic community doctor. So that stimulated an interest, at least for me, in that general field. And then, again, like a lot of us, I played sport. So I played a lot of football, soccer, not American football. I'm far too small for that. And I just loved being in and around the locker room. I love the camaraderie. I love being part of a team. And ultimately really enjoyed the sport. But in those days, when we're talking about the 1980s and 1990s, really you made a choice. You either continued to study or you dedicated yourself full-time to sport. And in my case, the odds were stacked against me making it as a professional sport. So I thought, I'm going to pursue my interest in health and wellness. I couldn't really decide what exactly I wanted to do in terms of specialization, and perhaps that wasn't as important to me as just being in and around and working with patients. But I knew from experiences and shadowing different practitioners that my philosophy would develop into something which is never accept that something's as good as it can ever be. And that was what provoked my curiosity and my studies and has guided me through my career.
Nice. So your background started with in the university to study chiropractic.
My first degree was in human physiology at University of Dundee, and I had the most wonderful educational experience there. But in the 1990s, when I graduated, there wasn't really a lot of outlets for physiologists and exercise physiologists. That wasn't very well developed in those days. So you could either continue to do research, go into pharmaceutical sales, which really philosophically for me wasn't something I really wanted to do, or transfer and study medicine or one of the allied health professionals. So after taking a little bit of time to consider which direction I wanted to go, I realized that, well, what did I enjoy? I liked getting hands-on. I liked being directly involved in decision-making processes, and I like trying to help people effect changes. So that narrowed it down really to me for, physical therapy, athletic training, and chiropractic came way out of left field. That wasn't even really in my initial choices, but I happened to go shadow. I worked in a hospital for a time and worked in a physical therapy lab. I worked with occupational therapists and everything really. And it was a chiropractor, an Australian gentleman, and he had a patient who came in, and I think she reminded me of maybe my grandmother. I just really related to what he was saying to this patient, which was, you've been to the doctor and the doctor said you have pain because you're old, and they've told you really there's nothing they can do for you, but never accept that something's as good as it's going to be. And I thought, that's it. Like, that speaks to me. So then from there, I then went and studied at the University of Surrey for an accelerated program in chiropractic, because ultimately I'm kind of impatient, so I just wanted to get it done with. So instead of doing another 4 or 5 years, I was able to knock out in 2.5. and then started practicing in the mid 2000s, about 2003, 2004.
Yeah, more than 20 years.
Yeah.
How old are you?
Getting up there. I'm 45. Yeah.
Good, good. And what type of client do you see in your studio?
So in the
clinic?
Yeah, in the clinics, these days we see a pretty broad base. The clients that I think the niche clients that I see or find their way to me. We work with concussive patients, so people who've had traumatic brain injuries, minor ones, not major ones, as well as athletes. I have a particular love at the moment for youth athletes and long-term athletic development, because I have 2 young kids who are heavily involved in sport, and that again stimulates my interest. So it's given me almost a renewed vigor. So I love working with the young athletes. We do a lot of baseline testing, and we do a lot of rehab.
Okay, and so today you work with a large community, large population, and athletes too,
Yeah.
right? Which type of sport most of all?
I would love to say football, soccer, but in reality in the States, the majority of athletes I'm working with are actually a lot of retired guys that have played professional American football. We have a few basketball players who come through, and obviously a lot of hockey players, which is the sport that my
in Dallas there is Dallas Mavericks.
And the Mavs. Yeah,
Mavs.
The Mavs are down there. So and I know the staff at the Mavs well, and they really run a great operation there. But what I really like about the Mavericks are maybe less the team and the team of the staff they have there, is that they're very open to collaboration. Cool. So I see them outsourcing specialists from different areas for analysis, for testing purposes, all for the greater good of the team and for the players. And I really relate to that philosophy as well. So there's some great practitioners in Dallas that I have the chance sometimes to be around as well and learn from.
Good. And one hot topic that I want to share with you, and I want to learn from you, is BFR, blood flow restriction, because you have a lot of experience on it. So you can tell me more about.
Yeah, so we use the acronym BFR, short for blood flow restriction, or sometimes we'll say BFRT, short for blood flow restriction training. And my nomenclature for it is just BFR is the application of the process, or what we do with maybe patients in the clinic when they're rehabbing. And BFRT might be if you and I decided we were going to go and try to get a pump on in the gym, we'd pump them up and we'd go for it, and then I guess take pictures of each other for Instagram. But so my interest in BFR stemmed from, I think it was back in 2017 or 2000, it would have been 2017. I'd seen it and been aware of it since about 2015. And just for context, the leading researchers, at least in the United States, have been working with this modality since 2008, 2009. And from my understanding, it originated in Japan, Katsu training with Dr. Sato. So it's relatively recent in as much as it's a medical or training intervention that's applied systematically now as it is. So I saw a professor called Stephen Patterson speak on blood flow restriction in Belfast a number of years ago, and that stoked my interest because it was from what I saw, it was a modality or an application which allowed you to create hypertrophy, but at exceedingly low loads. So it almost seemed too good to be true. But then it also seemed to have applications for aerobic training, improving VO2 max, balance training, working with a broad base of population that would really benefit from hypertrophy and being able to do resistance training. So that was what stimulated my initial interest in it. And then also just for personal use, I think if I can find something that means I have to work less but get more, that's going to be good too. And there, we started using a very small population in the clinic. I rehabbed myself through a number of injuries with it, grade 2 quadricep, grade 2 hamstring. And the one thing that's the most remarkable thing with it is that you can, you're going to be much more aggressive with your own personal rehab because you're not going to litigate against yourself for malpractice. You'll just think, well, I did something stupid and I won't do it again. But you can be much more aggressive with your own treatment than you might be with a patient in a clinic. But what I found was, let's say after a grade 2B hamstring tear, I was already within 24 hours on an exercise bike using BFR because it has analgesic effects and because I know that I'm stimulating muscle growth under lower load, which means I'm not interrupting the healing process, but I'm not losing muscle mass as quickly, and I'm still getting that workout in that I feel like I need. So just a huge, seemingly massive list of benefits or reasons to use it.
Nice. And so, in your experience, what is the population most suitable for about BFR?
So if you think about it broadly, there's a fairly large population of people that may not want to do heavy resistance training. It might not be appropriate for them, or it might just be that they're in a phase, let's say a pro athlete, it might be in the phase of a season where they just can't do heavy resistance training because the recovery time is too long and they may have games coming up. But we also know that training in season helps to maintain tissue quality and avoid somewhat that degradation of performance as the season tails on. So broadly speaking, somebody that's I would call it somebody that's not a candidate for high intensity resistance training.
So there are some red flags that you consider when you start to use the BFR with some patients?
Yeah, you'd want to be particularly diligent. First of all, over a certain age, but as soon as you start dealing with special populations, whether it's of advanced age, so let's say over the age of 65, any sort of metabolic considerations, so diabetes type 1 or 2, although there's some evidence that it may actually help with insulin resistance to use BFR training. And you're particularly cautious with any individual who's had a thrombotic event, an embolism or deep vein thrombosis, or even a propensity towards those types of things through genetic conditions. So those are things we'd screen for.
So how do you recognize, or how is your diagnosis on it?
Well, it depends where they've come from. So at least in the state that I work in, a chiropractor is a primary care physician of sorts. So somebody could just call you up, make an appointment, maybe never seen any other specialist before. So you want to be, first of all, very diligent with your history. So assuming they have assuming they're coming in for some type of musculoskeletal complaint, you're going to take a history. And the purpose behind the history isn't necessarily to focus on the issue, but it's to just ensure that there aren't any underlying medical conditions or familial conditions that might make you cautious. So the ones I've mentioned previously, hypertension might be one, because we are messing around with the cardiovascular system, albeit very safely. And then you want to get a list of the medications, and particularly in the United States, where we are probably more heavily medicated than, well, it's a fact. We consume more medication in the United States than any other country in the world.
Yeah.
So you just have you'd have your sort of spidey sense on for anything, warfarin or Coumadin or something that might suggest that there's been a clotting issue there previously. And then any history of cardiac complaints, stroke, MI, those would be big flags. And then secondly, that's cancers, any surgeries recently, just anything that may have involved an invasive surgery when the risk of embolism or thrombosis is slightly elevated. And there's actually a screening form, and I believe it's called the Improve screening, where you can then get a score based upon the relative strength of the different risk factors. Okay. And then from there, you just have to be a clinician and say, is this somebody on balance that's going to benefit more than have risk from this procedure, or does the risk outweigh the benefit? In which case, I'm going to need a very, very, very good reason to want to do it. And then usually I'll consult within their primary care physician if they have one, where
But my question is, how do you investigate? You do one questionnaire or blood exams? How you do?
Yeah, in the main it's history. In the main it's history. So we'll take a full history from them. We'll see what their goals are. Are they realistic? We'll go through that screening questionnaire I mentioned, the improved screening questionnaire. Then a review of systems. So just have you any issues in, with your hormonal axes, any issues with your digestive system, and the same as we do with any patient who came through. And then finally, when we have them on the table, we'll take vitals, just like any physician would do, blood pressure, heart rate, respiratory rate, temperature, just to make sure that that's all okay. And then we have other screenings. So if somebody's at risk, we can take the ankle brachial index, which gives us a sense of if they have a peripheral vascular issue. And if they clear all of those, and we determine that they are a candidate for some type of resistance training, then in reality, the risks of doing BFR-related training are no different than if you were doing resistance training. So in actual fact, if somebody's a candidate for resistance training or exercise, then they're also a candidate for BFR. It's just a slightly different form. So majority of people it's very safe for, but as with anything, you just don't want to leave yourself or your patient at risk. So
it's a young practice because he's how much? 15 years, 20 years?
Yeah, 1970 was when Dr. Sato started doing it with Katsu.
And in your opinion, how easy is to implement it in your clinic, in your practice?
Yeah, I think if you know how to take blood pressure, and you can take a history, and you understand how to prescribe exercise, then that's all you need. You just have to understand loading and intensity and how to play a little bit with those variables. Then it actually opens up a lot of opportunity for populations that normally you think would benefit from resistance training, but maybe you wouldn't feel comfortable putting them under a heavy bar. Well, all of a sudden we can exercise them at 20% of their maximum and enjoy a lot, not all, but a lot of the same benefits as you'd get from heavy resistance training.
So you are also a trainer for this method in US and around the world, in ATS too. What is the feedback you have from the professionals that use it?
The majority, where I see it implemented the most is actually in professional sport, because it works very well with that time-poor population. I want to get as much as I can from as little time as possible, or I want to accelerate through the early stages of rehab as quickly as I possibly can. So the feedback I get from the athletes is largely they like it because it simulates heavy resistance training, and most athletes are ultra competitive and love that feeling of having a hard workout, but the recovery is much faster. So the subject that's having it done largely really like it when it's applied well. It's hard work, but it's not painful, and they don't typically get they don't always get the DOMS or the feeling the day afterwards, so you can really do more with them. And then with the clinicians, I think once they get over the initial barriers to implementation, the questions that you have answered, well, what type of cuff should I get? What sort of occlusion pressures should I use? Where do I place it on the limb? How do I fit it into my practice model? Once you can remove those barriers, then it becomes very, very accessible, and exactly the same way as you would do your training. And in actual fact, I would say you might get more out of a 20 to 25 minute block of training with the BFR on than without it.
Kinesiologia, l'opera più completa, chiara e aggiornata sulla scienza del movimento umano, applicata alla salute e alla performance. Master professionale d'eccellenza ed innovativa videoformazione presentata da Istituto ATS e sportscience.com insieme a scienzemotorie.com.
So, how the people can learn more about BFR, and if there are some studies that you suggest?
Yeah, so there are a number of course providers. So I studied with Johnny Owens Recovery Science. They were really I don't know if I'll say they're the original, but they use a very rigorous method of training and certification, which is what I originally took to make sure that I had done my due diligence before I started implementing it. And that's a great group of individuals and a great resource for learning about BFR in the clinical population. The key researchers are there's Jeremy Lenicky at Mississippi. There's Jamie Burr, Stephen Patterson at St. Mary's University. And I don't want to miss any of the key ones out. There's also from Japan, obviously, because that's where this idea originated. Abe was the original study who on aerobic training with BFR. So there's some real key papers that you can pull out that talk about position statement on BFR training. There's a lot of focus on safety for obvious reasons, and a lot of focus on dosage. You know, what's the right amount of pressure to use, and what's the right RX when you're determining how much work should I do with the cuff. And then can you do other modalities? Can you do isometrics or continuous training, like a sled push, for example? So those would be the key players. And then we're obviously working on a course ourselves. I do educate. Largely, I do it within my student population at the university. So we want to make sure that when people graduate, that this is already something that they're competent and capable of doing. So I probably educated hundreds of students through the university systems, not just the one I work at, but around the US, and on workshops to make this as accessible and easy as possible, because I really believe in the benefit of it. And I think it comes into its own in the individual practitioner, so the person with a small clinic that wants to do rehab, but maybe they don't have the budget for racks and for weights and for everything. But they can be very effective with a small amount of equipment and some BFR cuffs.
Yeah. So you suggest one specific type of tools to use BFR?
No, not particularly. I think.
Yeah, I ask you because I saw that somebody used the elastic band, or somebody else used the professional tools.
So now this might be because I'm practicing in the United States, but I also think it makes sense. Is that if we always want to take a personalized blood pressure before we know how much to apply, because that means that we can get the predicted effects as closely as we possibly can for you or for me, because we might be different. The reality is when a bodybuilder or somebody who's training in the gym uses a wrap or some type of compressive implement, they don't know what pressure they're compressing at. And they may hurt, you can cause transient nerve damage, you can hurt the blood vessels, you can certainly overcompress. I really haven't heard of anybody causing themselves any permanent damage, but I know that would be very painful and might cause you to lose training days. But for an individual, I mean, that's fine. If you tell me that you're going to go to the gym and you're going to use some wraps, I'm going to say, I wouldn't do it that way, but good for you. Have at it. Let me know how it goes. In a clinical population, we want to be documenting things and writing down what we did. Number one, so that we can repeat it the next time, so we can have patient feedback. You know, did I overdose them? Did I underdose them? Are there some modifiables in there? But also, if you're working with a patient I'm working with, if I'm just using a wrap, I'm just going to say, well, I wrapped his bicep. I mean, that's not going to be useful to you, because you're going to say, well, how hard did you wrap and where did you put it? Whereas if you can standardize it and use a validated methodology, it just becomes much more rigorous and adds to the level of safety and surety that you have. So for that reason, there are cuffs which you can either use a handheld Doppler, like you would have seen me doing earlier.
I saw.
Or you can use an automatic cuff, which works in the same way as the blood pressure cuff that you might use in your office, the same technology.
Yeah.
And from there, it will calculate a personal occlusion pressure. And then you as a clinician, you may determine where you want to put the patient on that, depending upon the patient.
But I'm very curious, and I'm very curious also to know your point of view about the future of this practice, because which type of market do you think that will take the BFR? Because I hear about BFR from some of the best professionals, even in Italy, in the major leagues of soccer. and I know that he's evolving this practice. So what is your point of view from now to the future?
I think we have to ascertain what is it actually doing, because we know it causes hypertrophy, but we don't know necessarily if there's a relationship between hypertrophy and muscle strength, although the two seem to be associated in some way. But there's been some really interesting work on analgesia. Can it drive pain relief? Then the other parts that you start to see coming out is what effect does it have on a metabolically challenged population? So somebody with insulin resistance, that's pre-diabetic to diabetic. Now, what change can it affect in that population? And then does it become a very powerful intervention for more general medical conditions in that way? So for me, I'd like to see it as a gateway for people who, and let's face it, the world is getting less and less active. For me, it's a gateway. I'd like it to be a gateway for people that, as they age, lose muscle mass. So age-related sarcopenia, which goes hand in hand with fall risk, which goes hand in hand with healthcare burden and expenditure, but also in the family. And we're in Italy here. Family is everything.
Very important. Yeah.
So, what if I could do something for grandma so she doesn't, or is less likely to fracture her hip? Could you have group sessions where people come in and they spend 20 minutes working with a professional doing blood flow restriction classes at very low loads? That's what Katsu do. They go very low load and then build up. So I think it's the mechanisms are no different to heavy resistance training. But I think the extra caveat is when we drive muscle growth or change, there's the mechanotransduction component of it, where time under tension creates a hormonal cascade in the muscle, which then drives hypertrophy, muscle growth. But there's also the metabolic component, whereby we're compressing a limb, which allows fluid to get in, but it can't get out. So it starts to swell. And you saw this morning that our patient started to experience swelling in the limbs. It was safe, and it wasn't a bad type of swelling. But that traps, the lactate and the metabolites that build up when the muscle works in that area for a prolonged period of time. So that mechanotransduction plus the metabolic factor, there must be some type of interaction there which is driving this hypertrophy, this muscle growth. But what else does that do from a hormonal point of view if you have this accumulation of metabolites? And what does it do to the vasculature? They believe that it changes flow-mediated dilation and general health of the cardiovascular system, particularly the peripheral vasculature. So I think that's interesting.
A lot. Yeah. A lot. And what are some precautions that you suggest? Because we talk about the advantage, some risk, but it's very important, in my opinion, when we talk about one topic like that, to invite the people to use safely this type of method, even because you are a chiropractor, okay? And we have to study before to use it.
Yeah. So I think it's just about being responsible and respecting the tool, respecting your profession, respecting your patient. And if you can act in a responsible way, then you will do your diligence. So what would we, in terms of risks, very few, but we'd want to be cautious about the pressor reflex. So, if somebody does have high blood pressure, we probably want to monitor their blood pressure as we're going through these types of exercises, because obviously you're creating a peripheral restriction. Yeah. So that's going to put a little bit more strain on the heart, and that's going to change cardiac output. Maybe that's a good thing. Maybe you're increasing the efficiency of the heart and increasing the left ventricular strength in a good way. It could be good. But again, we're dealing with the cardiovascular system. So we want to be very sure that they're healthy and they can at least sustain a little bit of load or strain on that system. if there's somebody who exercises regularly or has done, and they haven't got any red flags, I wouldn't be worried about it at all. Other things you want to just be mindful of is it is very, very, very hard work. The level of effort and intensity is very high. There is 1 or 2 reported cases of rhabdomyolysis in the literature, and I literally mean 1 or 2. That's not to say it doesn't happen more, but that's what's been reported. So whilst there may be mitigating factors for that, we just have to make sure we rein people in. But a lot of that's about dosage. What's the right amount to do? And let's start easier. We don't have to come in here. We can start at a very, very manageable dose. Sometimes even let the patient select, but let them select on the easier side. So know the person you're working with. And if they can complete the protocol, then next time you just load them a little bit harder, about 5%, 2.5%.
And in the case you find one effect like the rhabdo you told me now, what is the suggest for your client? Well, because one professional can live this moment, and it's very important to know the protocol.
Yeah. So, I mean, typically, the way that rhabdo would present is that they would tell you that there was an excessive. Rhabdo, from what I've been told, feels like having DOMS, but x 100. So, localized swelling, redness in the area, extreme pain, potentially changes in urine color, and those would all be signs of impending rhabdo. Pain, definitely pain and swelling, tenderness over the involved extremities, that muscle's under extreme duress. So if I hear that, it's a urgent care or emergency room visit. So they want to consult with a physician as soon as they possibly could, because it can escalate quite quickly and it can be quite confusing. So that goes straight to emergency room type situation where they'll have blood work done. They'll check their creatine kinase to see what the levels are like in the blood, if they're excessive, and it can, in extreme cases, lead to a fairly prolonged hospital stay whilst that gets back under control, because it can overload the kidneys and create a lot of downstream problems, no pun intended, from there. So those would be very extreme, but that would be the normal sequence of events. I shouldn't say normal. That would be the expected sequence of events if, in the unfortunate case that somebody overexerted themselves. But there would almost always be some sort of other factor involved, either extreme fatigue, extreme travel, extreme exertion the days leading up to that, dehydration, usually the perfect storm of events, which is why the history becomes very important. Because if somebody's coming to you in that sort of state, maybe you're not going to exercise on that day anyway.
Prevenzione, rieducazione e riatletizzazione. L'opera più completa al mondo per esaminare e apprendere i protocolli scientifici, attendibili e aggiornati, volti a ottimizzare la prevenzione e il recupero fisico.
So I have another question, because I know that you have young kids.
Yeah.
And I would like to know your point of view about the long-term athletic development between US and Europe.
Yeah, so this is something I never really thought too much about until I had my own children involved with sport and became involved in the community. And in the United States, one of the things that becomes very obvious is that people's identity is wound up into their sporting prowess, their parents, their own. And it creates an interesting environment where youth sports becomes almost professionalized. And what I mean by that is there are a number of private clubs that charge large amounts of money and try to encourage, maybe I shouldn't say try to encourage, but facilitate early sports specialization, which we understand largely from the experts in the field, as well as the athletes themselves who are playing at the professional level, may not be necessary in order to become elite in a chosen sport. The difference then is that the parents tend to drive the athletic development, whereas I found in the UK, if you were good enough or played at a certain level, well, the clubs would come looking for you, and then you would become part of their youth program, and then hopefully once you got old enough and stayed in there, you might sign professionally. Whereas in the US, they have the collegiate system, so everything is sort of geared towards it's geared by a fear of missing out on something, but there's really no defined pathway to get there. So what people end up doing is they throw a lot of money at it, and there's, as you know, no shortage of people in the world who will take money, and it creates this almost faux professionalism of developing sports, sometimes at the expense of healthy athletic development. So developing healthy movement patterns, movement fundamentals, throwing, catching, jumping, landing, skipping. Sounds a little cliche, but that's what I see.
Yes, it's completely different markets. So in number, can you tell me the difference between US and Europe?
Yeah, from a cost perspective. So if let's say my kids play hockey, so for a 3-month season of recreational level hockey, now they are good, but they're not professional. $1,500 is what I'll pay for each kid for maybe 20 games and coaching. But by the way, the coaches are volunteer. It could be me, it won't be, but it could be me coaching. If they were to go to the next level up, which would be considered travel sport, or in soccer, football, they would call it club sport. But the same applies for volleyball, gymnastics, football less so because of the nature of football in the United States. You're starting to talk into the realm of tens of thousands. So if I put my kids at 11 years old into a travel team, I wouldn't expect much change back from $15,000.
It's insane.
It's complicated, to say the least. And then if you, the objective being ultimately that, can they get a scholarship to go play and get what they call a free ride through university? So instead of having to pay $100,000 for the degree, the university sponsors them to be there. And in actual fact, now these athletes at college can also be paid a salary, which is something quite new. But the probability of that it's in the decimal places of percent of individuals who make it. And that's not to say that I would ever turn around to anybody and say you're being unrealistic, but I think you have to be pragmatic and say, aside from the cost, what is that taking away from what are you taking away from your child at the expense of other sports and other experiences that children should have to make them dedicated to this sport to the tune of $15,000 US? Now, if you contrast that with playing football in the UK, for example, well, you get football through school. You get community football groups. There's always an outlet. And oftentimes the only thing you're going to pay for is field rental and the referee, which are usually covered in your season dues. There aren't private clubs, and the private clubs are academies, which are run by professional teams. So you get invited to go to those. They will run off-season training camps, but maybe £100, £150 for a week of coaching with a group is a completely different animal.
It's very interesting because in Italy it's completely different. I think for it there is much more ethics in sport, and I hope that we can recover the ethic of our work, because it is very important for the young kids, for the parents, for the family, for the future of all the society. So thank you very much, Nicky. Everything was very, very nice and very high quality informations, very high quality knowledge. Thank you for sharing with us. And I want to invite the people to follow you about BFR. Much more contents will be available on sportscience.com, a large platform in the sports science. And it was really a big pleasure to have you here in our talk show. Well, thank you very much, and see you soon.
Thank you.
Keep in touch. Goodbye.
Sportscience.com è la piattaforma numero 1 al mondo per la formazione professionale certificata per lo sport e la salute. Accedi adesso a centinaia di sessioni tecniche e formative con i migliori professionisti, docenti e ricercatori a livello internazionale. Qualificati e consegui online le certificazioni e diplomi ufficiali ATS e Sport Science. Sportscience.com, leader internazionale nella formazione e nell'aggiornamento professionale in ambito di scienza applicata al movimento umano per la salute e la performance.